Good afternoon. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership here at Harvard Medical School, and I want to welcome you to our 2018 Alvin F. Poussaint, MD, visiting lectureship. This is always an exciting time for us at the medical school. It's a time that you might almost call a homecoming for some of our alums and the illustrious individuals who've walked through our halls, and a time for us to honor and recognize someone who's part of the foundation of our school, and clearly a foundation as we think about diversity within Harvard Medical School and nationally, and that's Dr. Alvin Poussaint. We are so pleased that Dr. Sierra Washington has agreed to be our Poussaint lecturer for this year, an HMS alum. She's an associate clinical professor in the Department of Reproductive Medicine at UC San Diego, and the immediate past medical director and chief medical officer for Planned Parenthood Pacific Southwest. Planned Parenthood Pacific Southwest has 17 locations across 3 counties in Southern California. She has overseen clinical initiatives in the United States, ranging from California to New York, and in multiple countries across the world, but particularly in Africa. Programs and efforts are really around this intersection of HIV and reproductive health: Zambia, Cameroon, Kenya, Rwanda, and Tanzania. She's been the Director of International Programs for the Department of OBGYN at Indiana University School of Medicine, and Co-Field Director for Reproductive Health at AMPATH USAID, Kenya. She's at visiting appointments in multiple institutions and has published in many journals. But here's somebody who came to Harvard Medical School who made a big difference here. She was one of the originators of FABRIC. Does everybody know what FABRIC is? Well, maybe she will tell you towards the end, or someone can ask a question. It's an amazing program that our students put on here at the medical school that really represents, in a true sense of the term, the diversity and inclusion and the richness of our community and our environment. But she had the vision to help start that. But she's someone who's been deeply committed to issues of equity and social justice and quality of care for all individuals, but particularly those from the margins. And with that, Dr. Sierra Washington.
Thank you for the introduction. I have to say, when I was first asked to give this talk, I was a bit shocked and surprised to be asked to come back to Harvard because I am not a leading clinical researcher. I am not an author of some pithy bestseller. I haven't written a TV best series. And so then I had to sit with it for a minute and realize that I am a good storyteller. And I am a practivist. And I have had the privilege and honor of making my practice my activism. And although the path has not always been straightforward, it's been very interesting. So I'm so honored to speak today about a topic that's near and dear to my heart. So this is school. Pop quiz. There's a lot of melanin in the audience, so I'm going to expect a little bit of audience participation, please. Okay, so this is a map of a disease distribution where dark orange is a high prevalence of disease and white is a low prevalence of disease. So what disease am I talking about? And those people who've talked to me already today are excluded from answering. Yes, in the back row. Okay, Chagas. Good try. Anyone else? Only Chagas. Any other diseases that are profoundly affecting the continent? Yes? Okay, maybe tuberculosis. Any other diseases? Yep. Okay, infant mortality, yes. Malaria. Any final additions? Maternal mortality, And one last in the back row. Syphilis. Okay. So I'm just going to pause for a minute and tell you about my friend and patient, Diana. So Diana was a patient in Rwanda where I worked from 2012 to 2014. And I was there teaching residents about contraception and abortion when I took care of Diana. She was 19, and she was from a small village, and it's not uncommon in Rwanda to walk over hill and mountain to reach the hospital. She came to the hospital with abdominal pain, fever, and foul-smelling discharge. And the residents took care of her, as they do, and they decided that she needed surgery. So they opened her abdomen to find a fetal skull, approximately 20 weeks in her abdomen, and a hole in her uterus. In Rwanda, as in much of sub-Saharan Africa, a woman's worth is honestly defined by her ability to have children. And without a uterus, it's unlikely that a woman will get married. She may not have access to land security, food security. She may be socially ostracized from her community. So the residents, subconsciously taking all of these decisions in mind, decided to save her uterus. And they cleaned out the fetal parts, sewed up her uterus, washed out her abdomen, and sewed her back up again and sent her to the ward and put her on antibiotics. The next day, she was still febrile, so they took her back to the operating room. They found more pus in her abdomen, so they washed her out again and closed her abdomen back up and sent her back to the ward and added another antibiotic. And then the following day, she was still febrile. So they took her back to the OR, and they found that her bowels had become matted together, and there was a little bit of black tissue at the top of her uterus. So they cut that away. They washed out her abdomen, and they sewed her back up again. I learned about Diana after she'd already had 3 laparotomies in the morning report. And the students and residents reported a patient who had a burst abdomen on the ward. A burst abdomen is what Rwandans would call, what we would call dehiscence. And that she was febrile on the ward with a burst abdomen. And when I went to the bedside after hearing her story of already having 3 laparotomies and being 40 degrees, I saw a small girl who was 40 degrees Celsius, sweaty and weak, and she looked up to me and she said in Kinyarwanda, "Nachoka, nataka kufa," which means I'm tired and I need to die. And I looked down to her and I said in my broken Kinyarwanda / Kiswahili ki something, with some translation, that you don't have to die, but you have to have the will to live. That's number 1. And if you do have the will to live, I think we can heal you, but we're going to need to take your uterus out. And she consented. So we took her back to the operating room for a 4th laparotomy. And this time what we found was her uterus was black and green and putrid. If any of you have left a steak in the fridge for a little bit too long, you know that smell of rotting meat. And when we opened her abdomen, she was rotting from the inside. She had gas gangrene. Her bowels were completely matted together. It took us about 5 hours to remove her uterus and cut away all the bad tissue, wash her out, put her on antibiotics, and send her to the ICU. The thing is, she's 19. So 4 days later, she got up and walked home to her village and went home. So now, which disease do you think this is? Although this map looks similar to HIV or tuberculosis or Chagas, it's actually a map of unsafe abortion. And the reason that it shares the same distribution are that the similar pathologies of globalized racism, gender inequality, and poverty that led to unchecked HIV or unchecked tuberculosis in the global south have led to unchecked amounts of unsafe abortion. The difference, though, is that deaths from unsafe abortion is clearly a political casualty. So let me pause and just say I have no conflicts of interest. Today I'm going to discuss the practical implications of the current U.S. foreign policy on global women's health with a specific focus on abortion. So a primer in epidemiology, 44% of the world's roughly 200 million pregnancies are unintended. And 50% of those unintended pregnancies end in abortion, so half. Of the 56 million abortions that occur every year, about half are considered unsafe. So that's about, of the approximately 300,000 maternal deaths, 1 in 8 is from unsafe abortion. So I remember 9/11. I don't know if everybody in the room remembers what they were doing on 9/11, but I'm sure you do. So on 9/11, I was standing in the BI on the medicine ward as a third-year medical student making rounds. And we walked into a patient's room, and we walked to see on the patient's little kind of airplane television screen up in the corner, 2 planes fly into the World Trade Center. And my chief resident at the time said a racist profanity under his breath. And I remember the flush of anger and embarrassment that I had that he had spoken these racist words in front of everyone. And it sticks with me. And what I think now is that the number of deaths from unsafe abortion is the same as 8 World Trade attacks every year, 8 of them. So to me, it's sobering to consider the billions of dollars that have been spent fighting the war on terror, the change in international policy, awareness, and global policy, not to mention the change in airport security that's happened since 9/11. To me, it throws in stark reality that women are not dying because we don't have enough money. No. Women are dying because we failed to put resources towards the issue and because we haven't decided yet to put value on their lives. And why not? Well, let's look at the global burden of maternal mortality. This is a map of the world where the territory size is made to be proportionate to the maternal mortality rate. So you can see that the bulk of maternal mortality is in Africa and the Indian subcontinent. And you can see visually here that poor women of color bear a disproportionate burden. The top causes of maternal mortality are indeed hemorrhage, infection, hypertensive disease, although globally 13% of maternal mortality is unsafe abortion. In sub-Saharan Africa, as much as 30% of maternal mortality can be from unsafe abortion, and the case fatality rate for abortion is 470 times that in the US. So usually the popular press really likes to separate the issues of maternal mortality and abortion. But I want to make it crystal clear to you. If we were able to eliminate unsafe abortion, we would reduce maternal mortality by 15 to 25% in one fell swoop. So it is the low-hanging fruit when it comes to global maternal mortality. So how does mortality interact with the legality of abortion? Well, this is a map of the world's abortion laws. Red countries are where abortion is illegal altogether or only permitted to save the life of a mother. And green countries are countries where abortion can be sought without restriction. Access to safe abortion is still extremely limited in much of sub-Saharan Africa and Latin America, as you can see. And in Africa and Latin America, over 90% of women of reproductive age are living somewhere where abortion is restricted. We know from research that the legal status of abortion does not predict the incidence of abortion. I want you to be armed with that fact. The correlation between the restrictiveness of abortion laws and the incidence is very low. The authors of this study, Gilda Sedge at Guttmacher and her cohort, they researched abortion data across every country and every major territory in the world using official statistics, published and unpublished studies. They have obtained statistics for over 1,000 countries, and then they used statistical methods to correct for underreporting where it's illegal. They found that in countries where abortion is available on request, 34 per 1,000 women aged 15 to 44 will undergo an abortion, compared to 37 women per 1,000 in countries where abortion is illegal, and that difference was not found to be statistically significant. In a more granular analysis, they showed that abortion rates in the world are actually lowest in places where abortion is freely available and contraception is accessible. So if you look at Western Europe, the case rate for abortion is about 18 per 1,000 women. However, some of the highest abortion rates are found where the laws are most restrictive, such as 34 per 1,000 in sub-Saharan Africa, 44 per 1,000 in Latin America, and 65 per 1,000 in the Caribbean, where laws are often the most restricted. Based on their work at the Guttmacher, we know that the legality of abortion doesn't decrease the incidence of abortion. However, it does affect the safety of the procedure. You can see here that as we move from least restrictive to most restrictive, abortions become more unsafe. And in the most restrictive settings, up to 70% of the abortions will be considered unsafe. On this slide, orange and light orange are unsafe, and green are safe abortions. We also know that low-income countries, those same countries that tend to have the most restrictive abortion laws, have the highest percent of women with an unmet need for contraception. So unmet need for contraception is kind of an interesting and funny measure. It's the number of women who are married or in union, who are fecund, so they could get pregnant, but who want to delay pregnancy or not be pregnancy, but are not using contraception. Shall I say that again? Okay, so they're women who are married or in union, they're fecund, so they're fertile, they want to delay or not be pregnant altogether, and they are not using contraception. So basically they're saying, if you don't want to get pregnant and you're not using contraception, you're going to get pregnant. Okay, so that's the unmet need for contraception. And not surprisingly, the lower income countries have the highest unmet need for contraception, and higher income countries have the lowest unmet need for contraception. Also not surprisingly is that within each bracket of income, those women who are the poorest and least educated have the highest unmet need for contraception. So we see this trend even in the United States of America. Not surprisingly, women with an unmet need for contraception also have the most unintended or mistimed pregnancies worldwide. This graph shows that of the 89 million unintended pregnancies in 2017, 84% of those unintended pregnancies were women who were using either no method of contraception or a traditional method of contraception. So when you add it all together, women living in the poorest countries, those same countries with very restrictive abortion laws, the highest unmet need for contraception, therefore have the highest risk of unintended pregnancy and the highest risk of unsafe abortion. Shown here on the left is the estimated that in the low-income countries, at least half of all abortions are unsafe, and in some regions in Latin America, as much as 75 to 90% of the abortions are considered unsafe. So, can we measure the impact of legalizing abortion on maternal mortality? Absolutely. Here I'm presenting data from a natural experiment in the United States that we call Roe versus Wade. This is data from the New York Vital Statistics Office in the years immediately after Roe v. Wade. The black line shows maternal mortality attributable to abortion with an abrupt decline in the immediate years after Roe v. Wade. And the gray line in the back shows maternal mortality attributable to childbirth with a slower yet steady decline. Another natural experiment is in Romania, where abortion was legal and widely available in the 50s and early 60s, and then was severely restricted as a part of a population growth policy. And so the first red arrow shows where abortion was restricted, and the second red arrow shows where the abortion law changed to be unrestricted and freely available. What you see in the yellow are maternal mortalities from unsafe abortion, and the green maternal mortalities from other causes. So you can see that over the years that abortion was restricted, maternal mortality as a whole increases, and the proportion of maternal mortality from unsafe abortion rises drastically. The year after abortion restrictions were removed, that maternal mortality rate dropped by half in 1 year. Another example of data. In 1996, after the fall of apartheid, South Africa introduced some of the most liberal abortion laws. In the 3 years following the legislation, they set out to scale up access to safe and legal abortion. In South Africa, the annual deaths from public facilities from unsafe abortions fell by 91% from 1994 to the year 2000. They had 425 deaths in 1994 and 40 just a few years later. Infection fell by half, and the number of women displaying evidence of interference either by chemical injuries, physical injuries, or foreign bodies fell by 81%. So what's the best way to reduce death from unsafe abortion? Well, what do you think, guys? It's simple, right? Meet the unmet need for contraception and provide some safe abortions, and we'll reduce death from unsafe abortion. With universal access to contraception, we would eliminate 75% of unintended pregnancies. That's 23 million fewer unintended births, 36 million fewer induced abortions, 2.2 million fewer newborn deaths, and 224,000 fewer maternal deaths. So contraception is the most cost-effective way of decreasing maternal mortality. For every $1 spent on a family planning program, we would save $2.20 on the same program for maternal care. So it's not just cost-effective, it's actually cost-saving to spend money on contraception. And for this relatively modest investment, we'd be able to provide family planning for every woman in the world. We'd decrease maternal mortality, and we know that delaying childbearing boosts educational opportunities for women, and in turn boosts women's status in society. So how much would it cost in total? What's the price tag? To fully meet the world's family planning needs, we'd have to spend an additional $6 billion. Sounds like a lot of money, but let's put that in perspective. That's the 2016 presidential election. Same price tag. That's 1 month of the Iraq War. Same price tag. So it seems like a no-brainer to me. Why aren't we doing it? Well, that's where we come in. The global gag rule. This is what happens when U.S. public opinion, U.S. abortion law and policy in America relates to the rest of the world. Simply put, it comes down to money. The lion's share of healthcare operational budgets in the global south actually come from the U.S. government, either in bilateral or multilateral arrangements. For most of the 50 years that the United States has been providing international family planning assistance, the U.S. program has been embroiled in abortion politics. The Helms Amendment, which was passed in 1973, I see some folks nodding in the audience, this prohibits federal funding from providing abortion for the reason for family planning, either domestically or internationally. Nonetheless, anti-abortion activists didn't feel that the Helms Amendment went far enough. And so the Reagan administration officials agreed by a congressional bypass, aka an executive order, during the Mexico City United Nations Conference on International Population. They wrote the first executive order called the Mexico City Policy, aka the gag rule. This gag rule disqualifies U.S. nonprofit organizations from eligibility to U.S. family planning assistance if they use non-U.S. funds to provide abortion services, provide abortion counseling or education, or to advocate for a liberalized abortion law. We call it the gag rule because effectively what this policy does is it muzzles free speech and it muzzles public debate around abortion-related issues. In that same year, socially conservative activists began accusing the U.S. Foreign Assistance Program of complicity in coercive abortion practices and forced sterilization, citing the annual contribution to the UNFPA, which provided family planning assistance in China. Ever since Reagan, from Clinton to Bush through Obama, Republican presidents have reinstituted the gag rule and defunded UNFPA, and Democratic presidents have rescinded the gag rule and refunded UNFPA. So, on January 23rd, this conspicuously white group of gyneticians, as I like to call them. Those are politicians who think they're also gynecologists. They signed the expansion of the Mexico City policy and renamed it Protecting Life in Global Assistance. The original scope of the ban, as I said, was approximately $600 million to cover family planning assistance. And that accounted for 50% of all the world's monies spent on family planning. The Trump-Pence policy now applies to all international health aid doled out by the United States government, totaling close to $9 billion. Predictably, on March 30th, another law, the Kemp-Kasten Amendment, prohibited the U.S. from donations to the UNFPA, citing the forced sterilization and coercive abortion work because UNFPA used to partner with China. We cut $33 million from UNFPA, and as an FYI, for a long time I never really understood what UNFPA actually did. But I've come to understand that UNFPA's role is to primarily partner with governments in a time of crisis, war, or humanitarian crisis. So basically, what happens in the time of war, take Iraq, take Syria, take South Sudan, they ship out safe delivery kits and contraceptive supplies to refugee camps because they understand that even in war, you still ovulate. And even in war, you still deliver. And so that is the primary role of UNFPA. So what is the impact of this expanded gag? I know we're a room full of doctors and scientists and public health thinkers, so I'm going to share with you the data. So in financial year 2016, the U.S. provided bilateral growth to 64 countries. And of those 64 countries, 37 of those countries allow for legal abortion beyond which is what is available through the gag rule. Most were in Africa. 27 countries did not allow for abortion in any case legal beyond the gag rule. So most of those countries were in Africa. The next largest region was South Asia. And in nearly all of those 37 countries, abortion is legal to preserve a woman's physical health. And in 28 countries, abortion is also legal for fetal indications. So where a country's law allows for abortion that is not permissible under the gag, foreign nonprofits will be prohibited from providing legal abortion counseling, or referral or advocacy, even if they use non-US funds to do that work. Where countries' laws do not allow abortion beyond the gag rule, the policy wouldn't curtail access to abortion, but rather would curtail advocating for legal changes towards abortion. In all cases, domestic and foreign NGO recipients of U.S. Global Health Assistance have to sign a certification and affidavit saying that they are in compliance with protecting life and global assistance to be eligible for any U.S. aid. In addition, any non-NGO that makes a sub-grant to another NGO has to prove that that NGO is also in compliance. So this is a map of abortion laws that receive countries that receive bilateral assistance by abortion law. And you can see that light blue countries are countries that will be most likely be affected by the global expanded gag. PEPFAR is also affected. PEPFAR stands for the Presidential Emergency Plan for AIDS Relief and was implemented in 2004 by George Bush. And he gave $15 billion to the 15 worst affected countries plagued by HIV. Now over $70 billion has been spent of taxpayer money on PEPFAR to bring the global HIV epidemic under control. It is by far and away the behemoth of global aid. In this group of 37 countries, you can see here that 25 of those 37 countries also receive PEPFAR, followed by 18 who receive maternal child health funding and 17 that receive non-transmissible disease funding. Together, these 37 countries that will be affected by the gag account for 53% of all of our global assistance. So unfortunately, under Bush's previous gag, we witnessed the disruption of funding of the largest and most established family planning programs. Here are two of them. We have International Planned Parenthood Federation and Mary Stopes. Similar to the Planned Parenthood Federation of America, the International Planned Parenthood Federation operates affiliates in each country, usually called Planned Parenthood Associates of Lesotho, Planned Parenthood Associates of insert the country. Mary Stopes operates clinics either in their own name or sometimes in a name that fits the local cultural context. But to be sure, whether they're in name or not, these two providers are providing an immense amount of critical services to women. So let me take you through a few illustrative examples. After President Bush reimposed the gag in 2001, a consortium of NGOs led by Pop Council organized a study to assess the impact of Bush's gag on countries. What they found is that USAID had to cut off a condom supply in 16 sub-Saharan countries altogether in Asia and the Middle East. In Lesotho, where I take you now, a kingdom in southern Africa, Lesotho received 426,000 condoms from USA and other contraception during the 2 years of the Clinton administration. Once the gag rule went back into effect, USAID had to end condom supply completely to that country because Planned Parenthood Associates of Lesotho was the only conduit that they were using to get condoms to Lesotho. Let me remind you, in Lesotho at that time, 1 in 4 people had HIV. So it's not difficult to imagine the impact of cutting off a condom supply in a very high prevalence HIV environment. Planned Parenthood Association of Zambia was the primary Planned Parenthood family planning provider for Zambians. They refused also to sign the global gag rule, and they lost their US funding as a result, and they dismissed about half of their staff, scaled back their reproductive health services, and specifically they had a community-based contraception distribution program that they had to end completely. Nepal has some of the highest maternal mortality rates in the world, and about half of the maternal mortality in Nepal is attributed to unsafe abortion. And due to the kind of extreme public health crisis of unsafe abortion, abortion was legalized in 2002, and now it's legal for any indication up to 12 weeks, and up to 18 weeks in cases of rape or incest, and up to any time if a woman's life or health is in danger. So the Family Planning Associates of Nepal provides about 25 to 30% of the total family planning services across the country. And they're in about 75 of the country's districts. They refused to sign the gag rule in 2001 and lost a partnership that was 32 years with USAID. They lost $100,000 from Engender Health, an implementing partner, and $400,000 of contraceptive supplies. So they terminated 60 full-time staff, and they had to introduce fee-for-service care in place of free care. In that same country, Mary Stopes International ran 27 clinics providing primary health care, family planning, pre- and postnatal care, abortion, youth-friendly services, and child-rearing educational services. They also ran a detailed community health worker program that went door-to-door providing family planning education. Sterilization is the most popular method of birth control in Nepal, and Mary Stopes provided about a third of all the sterilizations in Nepal. So they refused to sign the gag, and they had to cut their sterilization program, they had to cut their community program, and basically just restrict to in-clinic programming. Last example, I moved to Kenya right out of residency to co-direct a prevention of mother-to-child HIV program. And at the same time, I provided obstetrics and gynecology services to their second largest teaching and referral hospital. We had a 50-bed ward of a gynecology ward that was 50 beds. Of that 50 beds, 2/3 at any one time was full of septic abortion patients. It was not uncommon for women to start their abortion clandestinely using chemicals or street medications, and we'd often find evidence of interference when we went to the hospital. What I realized is I had moved there to work on the HIV epidemic, and I realized that HIV is kind of tucked in. And I learned that expression on the wards here at medical school. Tucked in is when you've set out the management plan and you just have to kind of watch it run its course. And so I felt like HIV was kind of tucked in. We had care and treatment programs for everyone, great prevention services, sometimes orphan and vulnerable children services, sometimes whole micro and macro nutritional programs. But the women who were HIV negative or HIV positive who suffered unsafe abortion were still left out to die. And yet the medical anthropologist in me saw immediately that those exact same social pathologies that allowed for HIV to flourish, that allowed for women to be infected with HIV, those are the same women that were falling victim to unsafe abortion. So in Kenya, what happened? Mary Stopes, they decided not to sign the gag rule. They cut funding. They had to close their STI program. They ran an STI program on the banks of Lake Victoria, one of the greatest hotspots for HIV disease in the world. They had to close that program. Family Planning Associates of Kenya closed 15 clinics between 2001 and 2005. And what I realized is that for these women who are walking their entire lives, when you close one clinic, they don't have another option to go to. So in Ghana, where abortion is permitted to protect a woman's health, as well as her life, her physical health, her mental well-being, and it's also prohibited in cases of rape, incest, or fetal impairment. So a relatively liberal law. The Planned Parenthood Association of Ghana, who was primarily funded by IPPF, was the country's oldest and largest family planning service provider. They lost $200,000 in US aid as a result of the global gag rule. They laid off 60 staff members, they reduced their nursing staff by 40%, and that led to a 45% reduction in contraceptive provision, primarily in rural communities. More than 1,300 communities were affected by the cuts. And the Planned Parenthood Association of Ghana saw 50% more women come to their clinics for post-abortion care the year after the gag rule was implemented by the Bush administration. Another study done in 2011 took a deep dive to look at the impact of the gag rule in Ghana and found that self-reported abortion rates were much higher during the gag rule than in the pre-gag years. While those case studies are compelling, the question is, does the data add up? As far as I'm aware, there are 2 studies that look at the population effects of the gag rule on contraceptive prevalence and abortion. So Jones et al., they took a deep dive into Ghana, and they looked at where were the clinic closures and who was affected. What they found, this map shows the service locations before the gag rule and the service locations after the gag rule. So you can see the people who are most impacted are people who live inland and away from urban cities on the coast. Key findings from another study by Dr. Ben David at Stanford are shown here. They evaluated women across 20 African countries who had induced abortions between 1994 and 2008 through using demographic health surveys. And what they did is they considered countries who had a high exposure to gag rule or a low exposure to gag rule. So a high exposure to gag would be if your country received at least the median amount of US family planning assistance before the gag went in place. And a low exposure to the gag rule would be if you're from a country who received less than the median before the gag rule went in place. So I always get the colors confused. So green shows low exposure to the gag, and black shows high exposure to the gag. You can see this is a graph of contraceptive prevalence. And so in countries that have a high exposure to gag funding, you see that contraception prevalence just basically plateaus during the gag, and contraceptive prevalence increases in countries that don't have high exposure to US funding. We see when we pool all 20 nations, here the dotted line is when the gag is implemented. So you see before the gag, the prevalence of the incidence of induced abortion. And then after the gag, you see an abrupt rise in abortion. They further stratified abortions by countries by low gag exposure to high gag exposure. And here you can see in the green countries with low exposure to the gag rule, abortion incidence stayed the same. But in countries with high exposure to the gag rule, abortions actually went up. So what are the indirect effects of the expanded gag? Well, remember that before, in this data that I'm showing you, the gag only applies to the $6 million spent specifically on bilateral grants for family planning. And now it applies to all foreign funding from the US. An important factor to understand when we look at the indirect effects is that Bush created PEPFAR for HIV, and Obama's mark on PEPFAR was to integrate maternal child health and newborn care into PEPFAR programs. So most of the money was spent in family planning, used to integrate family planning and maternal health programming into PEPFAR programs. And those same bilateral grants and those same implementing partners were using the monies to integrate services. So in much of sub-Saharan Africa, you have HIV prevention and treatment organizations that also provide sexual and reproductive health services. Many organizations have tried to kind of make almost a healthcare home where they integrate services under one roof. So they're treating young children, they're providing immunizations, growth, nutrition, contraception, reproductive health, and sometimes abortion care or post-abortion care. So you see that this new policy has the potential effect of a much broader public health program, including responses to Zika, HIV, other infectious diseases, and it actually stands to reverse global progress in promoting an integrated patient-centered care model. But what does it mean for us doctors who are just taking care of patients on the ward? As I said, I worked in Kenya at this program called AMPATH. It was a consortium of 11 universities brought together to provide education, care, treatment, and research. They have a $60 million grant in Kenya for HIV and a $5 million grant for MCH and primary care. Collectively, these 11 universities bring in about $84 million in research dollars. That's a lot of money. So this one program accounts for greater than $200 million in total funding. Remember that in Kenya, abortion is legal to preserve a maternal health, including psychosocial well-being, fetal anomalies, rape, and incest. And the Kenyan OBGYN Society supports liberalization of the interpretation of that law. When I worked there, I was not under a gag, it was under the Obama administration, and we tried to improve post-abortion care in the wards primarily by providing pain control and infection control. We often partnered with Mary Stopes to provide sterilization services within our HIV clinic for patients who had traveled from far. I was writing a small subgrant to get monies for family planning integration into the HIV program, which USAID called for the application when I received a phone call from the USAID representative for maternal child health to remind me that I could not put anything in the budget for any kind of equipment in the budget for post-abortion care because that same equipment may be used to provide an abortion. And that was under the Obama years. So through my conversations with USAID representative and subsequent research, I've come to realize that under the gag, none of these 11 consortium universities or visiting faculty who came to best part of that program could do anything construed as promoting abortion, let alone say the abortion word, could not partner with Mary Stopes to provide a safe abortion, could not refer a patient to Mary Stopes to provide a safe abortion, or advocate for local, regional, or national change. Technically speaking, this would mean that if we received U.S. government money now, under the current gag, we'd not be able to perform a pregnancy termination for a diagnosis like this. The OBGYNs in the room will know that this is anencephaly. We would not be able to use our own money to provide an abortion for something like this. We would not be able to purchase a uterine aspirator to help with miscarriage management or a Carmen cannula, which is used all the time for miscarriage management. We would not be able to purchase misoprostol, which is a life-saving medicine used for postpartum hemorrhage, as well as post-abortion care. And it led me to think, what about restrictions on medications like methotrexate? Before the advent of mifepristone or the abortion pill, methotrexate was used to promote as an abortifacient for medical abortions. And so potentially this medication that's used to treat molar pregnancy, and other cancers could also be restricted by the gag. Certainly, we'd be prevented from continuing a partnership with Mary Stopes. And so what's at stake? Well, funding for 180,000 HIV-positive patients with life-saving medications, not to mention partnerships with over 500 Kenyan clinics. But the question that I continue to have is how much can the US government say that you can and can't do before it becomes unethical and morally corrupt? So what about the macro and microeconomic impacts? So essentially, we know that keeping a woman pregnant or postpartum keeps her out of the workforce. That leads to less income for the family. And in a macroeconomic analysis, we know that less fertility is associated with a greater GDP and declining poverty. This happens because of a concept called the demographic dividend. The demographic dividend is a well-described economic occurrence that a country enjoys when you have accelerated economic growth due to a decline in fertility and a decline in mortality. The country then experiences low birth rates in conjunction with low death rates and receives an economic benefit from the increased years of productivity in that working population. Fewer births are registered and the younger of young dependents declines, and so the dependency ratio shrinks. The amount of people who are dependent on you shrink, and that means that you have more people in the labor force, more money to go around, and resources are freed up to be invested in other things. You see accelerated macroeconomic growth. So essentially, we know that an individual woman's economic empowerment and her equality rates rely both on her bodily autonomy to access family planning and to procure a safe abortion. And with that bodily autonomy comes economic prosperity. I'm not even going to get into the larger implications on democracy and free speech that the gag rule implements, because you can't even advocate the government for legalization of abortion. So what is the impact of the gag? Unfortunately, under both Reagan and Bush, we saw clear reversal with disruption of established family planning providers. We saw commodity shortages. We've seen more unintended pregnancies, increases in abortion, not decreases. We've seen decreases in birth spacing, which we know worsens maternal health outcomes, and we know worse maternal health outcomes worsens children's health outcomes, and we know that we see a negative impact on economic development. So for better, for worse, money does make the world go round. And this is a story of what happens when our own domestic politics around abortions and reproductive rights impacts the flow of cash in the global south. While we focus on our local and regional and national problems around abortion access, let us not forget that what happens here at home actually has grave impact on the globe. It impacts rates of unsafe abortion and maternal mortality worldwide. So remember that our fight here at home actually will have great impact on women like Diana, the story that I told at the beginning of this talk. One more thing for doctors. I think sometimes we think that we can be cloistered in our care of patients, and that our work taking care of patients is enough. But choosing not to be engaged in elections is not a neutral decision. That is not a neutral decision. If you choose to do nothing in the next election, it will have great impacts. So one of the cool things about Harvard that I've always loved is that it draws people from around the nation and around the globe, from districts all over the country. So I would encourage you to register at home, get your parents to register at home, and call your congresspeople at home, whichever state you're from, and remind them that women hold up half the sky. So I hope that today has been a sobering reminder and a detailed account of how the US administration actually jeopardizes women's health. By putting ideology before evidence, proponents of the global gag rule are undermining women's sexual reproductive health and our global economic development.